Welcome to the OPENPediatrics World Shared Practice Forum. My name is Judy Palfrey, and I'm the director of the Global Pediatrics Program in the Department of Medicine at the Boston Children's Hospital. This presentation is one of a series of forums focusing on common child health problems in the global setting. HIV infections remain one of those challenges around the world. We have the great good fortune now to hear from Dr. Rana Chakraborty, who is professor of the Division of Infectious Diseases in the Department of Pediatrics at Emory University School of Medicine. He's also the medical director of the Ponce Family Youth Clinic under the Grady Health Systems in Atlanta, Georgia. Also, he recently served as the chair of the American Academy of Pediatrics section on HIV. Welcome, Dr. Chakraborty.
Pleasure to be here. Thank you, Judy.
Rana, you've dedicated much of your life to the prevention and the care of people with HIV. Talk to us a little bit about what were the early influences in your life?
Well, thank you for that question. I think the first effect was sort of, as a medical student going on elective in Vellore, South India, I was managing a 50-year-old adult patient with AIDS. His worsening respiratory status at the time was attributed to pulmonary tuberculosis. But there was a 16-year-old wife in the room, and she was about 8 months pregnant. There was also a playful 2-year-old son. They both kind of left a real lasting impression on me. And so I discussed the case with the senior house officer, and he told me that speaking with the virologist, there were 200 known cases of HIV infection, and that was in a town of about 200,000 inhabitants. And then I discussed sort of the issues around disclosure to the patient's wife of his underlying HIV status, both testing her and that playful 2-year-old child for HIV, and also what measures we could implement to prevent HIV transmission to the unborn fetus. But I was met with silence, and that was in 1990. After that, a few years later, I actually went on and commenced residency training in pediatrics at the Bronx Lebanon Hospital Center between 1993 and 95. And in the preceding years, and during those years, the South Bronx had been, as you may know, had been markedly affected by the HIV epidemic. And this was apparent with HIV causing more than 60% of inpatient morbidity. And so while training, I cared for many patients with complicated infectious diseases, but really none proved more challenging than the infants, children, adolescents, and families with or affected by HIV infection. But it was during residency that third question just kept coming back to me from that experience in India 3 years earlier. What measures could we implement to prevent HIV transmission to the unborn fetus? Also note that in our NICU, we had estimated about 5 to 10% of infants were born exposed to HIV. A few years earlier, during residency, we had managed to sort of learn a little bit more, not only from some of the lay media, but the medical journals that were available. And we knew that 1 in 4 HIV-infected mothers transmitted HIV to the infants in the United States, that most infections occurred through transmission from mother to child, although the timing was unclear at the time. And that by the 1990s, early 1990s, about 16,000 infants and children were perinatally infected in the US, and that there was a real critical need to try and prevent. And this also played out in terms of disease progression. And there was some startling data that came out from Gwendolyn Scott's group. She worked in Miami, and she sort of demonstrated in a New England paper looking at survival, and the conclusion in her cohort was that in the absence of treatment, pediatric HIV infection in the United States was associated with, really startling disease progression, with about 25% of children dying by age 2. So that was the background. Judy, something incredible happened. I call it incredible. Halfway through through residency, the hospital where I worked at, Bronx, Lebanon, was chosen as part of the PACTG 076 site.
I have to interrupt you. That number, 076, just rings a positive bell in pediatrics. And you're going to tell us why.
I am, and I just felt so privileged to have been able to witness that as a resident, because I remember our attending sort of telling me and a group of residents around about early March 94 about the importance of the results generated, and that we had for the first time an evidence-based intervention that could prevent mother-to-child transmission, and that sort of helped put at least partial closure on that question that had been bugging me from that experience in India. So I want to tell you a little bit more about that trial and its implications, particularly in addressing that question, and where we've moved on in terms of our understanding. So about 076, at the time, the intervention involved giving oral zidovudine to pregnant mothers, and then providing intravenous zidovudine around the time of delivery, and then providing oral zidovudine to newborns as postnatal prophylaxis. And the remarkable thing that was shown by the group was that compared to the placebo, the rates of transmission dropped significantly to just 8.3%. And so for the first time in medicine, the group were able to demonstrate treatment as prevention. And so the DSMB had stopped the study, and the paper was very shortly published, I think, in the New England Journal. And with that, a number of health departments, including the New York State Department of Health, went about implementing these interventions to prevent transmission. Now, there were also other questions in terms of the timing, and that was obviously quite important. But with a 67% reduction, it was really critical to put in the components that were going to be able to make a difference throughout the United States and also other Western settings. Now, just quickly looking at a few questions around the timing, Athena Curtis and Andre Namias working in Atlanta had sort of suggested that a lot of the transmission events took place around the time of labor and delivery. And that's perhaps why it was important to give intravenous zidovudine to the mum at that time. But there were also estimates from Ruth and Duarte's group working out in Nairobi about the significant contribution of breastfeeding in mother-to-child transmission of HIV. But coming back to the US, the AAP and the CDC immediately expanded recommendations for selective testing of high-risk groups to voluntary routine testing of all pregnant women in the United States. And really, testing is really very much the platform upon which we develop base our other interventions around. And then following that, the Institute of Medicine, following from the AAP and the American College of Obstetrics and Gynecology, they recommended universal routine opt-out testing with patient notification, which meant really that HIV testing was given and said unless the expectant mother specifically indicated that she didn't want an HIV test.
So What other interventions have there been? And I'd really like to ask you a little bit about the role of cesarean section as you're talking about the transmission at the time of birth.
So this is again specific to the United States and Western Europe, and we'll talk about other interventions outside the West halfway through the talk. But there was some evidence that came in from the European Collaborative Study, and that was published in The Lancet in 1999. And they, as you can see in the graph here, when there was no prophylaxis and no cesarean section, the rates were up there at 20% with vaginal delivery. Elective C-section dropped that rate by 5-fold. But if you had that combination of both zidovudine and an elective C-section, your rates of transmission went all the way down to 1%. And again, this was really heart-rendering to actually see that we were really, within the space of just 6 years or so, we could even get to those kinds of numbers.
The excitement of 076 and the understanding of what was happening from this incredibly devastating disease, those were really important things that happened, and the idea of maternal-to-child transmission became a call to people. But what are the primary risks for...
And it's important to get into the science. These interventions were great. Oftentimes they were led by what we knew scientifically, but at that time we didn't have enough of a grip on pathogenesis. And so some of the evidence came a little after the interventions had already been put in. And the first bits really sort of came in from 3 settings, from the US, from the UK, and also from Thailand, where we sort of, investigators sort of demonstrated, again in 1999, that the higher your viral load, the more likely you were to transmit a virus, so that when they stratified above a viral load of 93,000, and viral load is sort of the number of viruses you can count by PCR technology for every drop of blood. And that the higher this value was, the more likely the transmission rates from this particular graph go up to about 40%. In contrast, when your viral load was under 10,000, your rates of transmission dropped pretty significantly. And then Ellen Cooper, working here in Boston, but working through the WIT study, really elegantly demonstrated again the effects of high viral load and the rates of transmission, which went up significantly. So when the virus was very, very high and there was no antiretroviral therapy provided antenatally to the mother, she was more likely to transmit to the newborn. And then in the UK, Claire Townsend and colleagues looked at over 4,500 women between 5 years, over a 5-year time period. And again, with viral loads this time greater than 10,000 copies, again, you were more likely to transmit. But if you look closely here, when mums had undetectable viral load, your rates dropped even beneath 1% to just 0.1%. Contrast that to where we were back in 1992, and the progress has sort of been tremendous.
So explain a little bit more how these antiretrovirals are bringing that load down and how it's working with the maternal-to-child transmission. And how do they work actually during the pregnancy of the mother before the delivery?
Again, this is sort of very emerging evidence, but sort of the viral load was key, and probably the most important mechanism. That the key thing was to drop maternal viral load. But there are a couple of other mechanisms that we think are also coming into play. So these 2 mechanisms we think are called pre-exposure prophylaxis, so that the drugs are actually crossing over the placenta and almost prepping the baby so that if virus does cross, then at least you've got a good concentration of antiretroviral drugs in the cord blood, which is likely to take account of any virus that crosses. And then obviously through post-exposure prophylaxis of the infant, if you continue to give medication, and the recommendations in the US are to provide zidovudine prophylaxis at a minimum for 4 to 6 weeks.
As part of the intrapartum recommendations in the US, I've heard that cesarean section and administration of intravenous zidovudine is no longer recommended for certain HIV-infected women during labor and delivery. Why is that? Where did the change come from?
Right. Well, I think obviously initially the interventions were put in quite strongly, and that effect resulted in excellent sort of reduction as demonstrated. But then afterwards, we're sort of in the process of what I call fine-tuning. And quite a lot of evidence sort of emerged, mainly from Europe. So Tariq presented some data in 2011, where you can see from this chart here that compared to elective C-section and vaginal delivery, rates of transmission were just sort of 0.8, 0.9%. There wasn't really very much difference compared to having an emergency cesarean section. And these were sort of women who had received combination antiretroviral therapy. And that was sort of reinforced by French data, where again, there was sort of no difference between an elective or vaginal delivery amongst women whose viral loads were less than 1,000 copies per ml. But they were a little bit higher amongst women who required an emergency cesarean section. So that's where the evidence came in that if mum was well controlled, was following up with her obstetric provider, taking combination antiretroviral therapy, and she was virologically suppressed beneath the level of detection, but here sort of less than 1,000 copies, then the chances of transmission were equivocal if she gave birth vaginally compared to mums who had an elective cesarean section. And to reinforce that issue, Athena Curtis had looked at 4 cycles and looked at sort of the effects of cesarean section on mum, because this can also be associated with infections in her and surgical trauma and so on and so forth. And so based on the fact that her rates were equivocal anyway, you didn't want to put mum at any further risk in terms of infection and trauma and hemorrhage and so on and so forth. And so all of that led to the recommendation that if there was virologic suppression, then we could perhaps not have to recommend cesarean section. Now, in terms of the use of intravenous AZT, there was some French data, and this was published about 3 years ago. Just over 11,500 women delivered between 1997 and 2010 in France. Importantly, if you look at the middle blocks here, the rates of transmission were 0.6% amongst mums who had IV-AZT, but had adequate virologic suppression antenatally, and was 0 amongst those mums who had no IV-AZT. And when their viral load was between 400 to 999, just less than 1,000, rates of transmission were again higher amongst mums who received IV-AZT, and again was 0 amongst mums who didn't receive IV-AZT. And so based on that, the recommendations from the Department of Health and Human Services in these guidelines that are updated annually for prevention of mother-to-child transmission recommend continued combination antiretroviral regimen during labor and delivery. That if mum receives combination antiretroviral therapy and her viral load is less than 1,000 copies near delivery, that the addition of intravenous zidovudine is not required. That the viral load, on the other hand, if it's greater than 1,000 near delivery or unknown, that in that instance, IV AZT would be recommended in addition to a combination antiretroviral regimen. And if viral load is greater than 1,000 copies near delivery, a scheduled cesarean section at 38 weeks is recommended.
It certainly sounds from this as if finding those mothers early, and you talk a lot about adolescent mothers, and getting them into care and getting that viral load down is the essential component to making this go more smoothly.
And that reflects what the CDC guidelines and the AAP guidelines in terms of screening all women back in 1995 who were pregnant, ideally in the first trimester, and in most settings in the US, in the third repeat testing in the third trimester was going to be a critical component to be able to initiate some of these interventions. Yeah. And then there was sort of more data, and this was published in the mid-90s on the effects of prolonged rupture of membranes, and the fact that if mums came in with a rupture of membranes, the longer those membranes were ruptured and you didn't affect a delivery, the more likely you were to transmit virus to the baby. Now, obviously, that's an obstetric decision, but that's also something to take into consideration with the concern for ascending infection.
So where did the evidence for the current U.S. DHHS guidelines on postnatal prevention come from?
So obviously from the PACTG 076 study that we talked about earlier, and that zidovudine prophylaxis could be continued for 4 to 6 weeks. We generally recommend 6 weeks in the US, although in Europe they have moved over to 4 weeks. Now, at that time, providers were giving zidovudine orally to the baby every 6 weeks, but you can actually give it, every 6 hours, but you can actually give zidovudine every 12 hours. And that's what we've switched over to. Now, the other critical determinant in this, and this was Nancy Wade's data published in 1998, really sort of showed that you've got to get the medications in earlier. Now, this was sort of data demonstrating the risk of transmission at 48 hours after birth, which had gone up to about 9.2%. But if you delayed more than 3 days, the rates of transmission went up to 18.4%. That's almost double. No, that is double. So the guidelines now in the US sort of say that it's important to start postnatal prophylaxis, ideally within 24 hours, 12 hours if you can. And then more recently, Karen Nielsen-Sains and colleagues working with the HPTN 040 study addressed the question of should we be adding another drug, especially in high-risk deliveries. And high-risk deliveries we've generally view as situations where the viral load is greater than 1,000 copies, or expected to be greater than 1,000 copies if the mum hasn't had any prenatal care. And so they did a multinational study with 3 countries, Brazil, South Africa, and the United States, and they had 3 arms. These were all high-risk deliveries. Babies received zidovudine prophylaxis in one arm alone for 6 weeks. In another arm, they received zidovudine and 3 doses of nevirapine, which is a non-nucleoside reverse transcriptase inhibitor. And then in another arm, they received lamivudine and the protease inhibitor nelfinavir for 2 weeks, in addition to zidovudine. And they looked then at sort of the outcomes. And what these investigators were able to sort of demonstrate was that rates of in utero infection were slightly higher in the arm that received zidovudine prophylaxis alone, and were a bit lower in those where babies received either zidovudine or nevirapine or zidovudine, lamivudine, and nelfinavir. But importantly, when we looked at intrapartum infection, sort of infection around that time of delivery, there were significant differences between arms 2 and 3 compared to arms 1, where just zidovudine was being given. And these differences were significant statistically. However, arm 3 was not recommended based on the fact that more hematologic toxicity was observed in infants who were in this group. And so, based on this, the current guidelines from the DHHS recommend standard infant prophylaxis of mothers receiving combination antiretroviral regimens of zidovudine, 4 milligrams per kilo twice a day for 4 or 6 weeks. But that if there is a high-risk delivery where mum hasn't received prenatal care, or if mum has a viral load near the time of delivery greater than 1,000 copies per ml, that 3 doses of nevirapine should be given, ideally at birth, and then with 48 hours later, and then 96 hours after the second dose. And these are the doses in the slide.
So what about breastfeeding in the United States? What are the recommendations here?
Well, the AAP don't recommend breastfeeding regardless of maternal viral load. Because formula feeding is readily available and we have clean water, that becomes less of an issue. But this is very specific to the United States and many Western settings, and certainly not in many other settings in the world. So I think I'm going to have a summary slide here of the recommendations in the US and in many Western settings that all pregnant women should be tested for HIV in the first trimester and again at the end of the third trimester, and that women with no antenatal care should receive a rapid test so that the provider can determine within minutes if HIV infection is an issue with those who haven't had prenatal care. That they should receive treatment for HIV if they test positive so that the plasma viral load is undetectable at delivery. That cesarean section be offered, an IV AZT be offered if your maternal viral load is greater than 1,000 copies, or if there's prolonged rupture of membranes in certain circumstances. That baby should receive postnatal prophylaxis, ideally within 12 to 24 hours of birth. That in the US, breastfeeding should be avoided and that suitable alternatives should be offered. And that providers should inquire about the practice of pre-mastication and counsel HIV-infected carers about more safer feeding practices. And that infants born to mothers with no prenatal care or a viral load greater than 1,000 copies, their postnatal regimen should include zidovudine and also oral nevirapine, at least 3 doses. And that infants should receive testing at birth within 14 to 21 days of life, at 4 to 6 weeks and at 3 to 6 months. And with that, we've seen a nice drop-off, as we talked about, in terms of infection rates.
This is great news for the US and Europe, but I want to take you back to your first experience in India in the 1990s. What are your recommendations globally, particularly in resource-poor countries where the viral loads may be very high, where the resources for interventions may not be quite the same? What are mothers supposed to do to protect their children there?
Yeah. Well, this is a critical question, and to answer this, I'm going to give a quote from Bude Sylvia Taylor, an 11-year-old Nigerian born free of HIV, speaking to world leaders in New York in 2010, said that no child should be born with HIV. No child should be an orphan because of HIV. No child should die due to lack of access to treatment. I think never really a truer word was said, in my opinion. So there are obviously issues. Many women are going to breastfeed, and those are certainly the guidelines from the World Health Organization in terms of in the setting of maternal HIV infection. And that's completely understandable because breastfeeding provides optimal nutrition. And in settings where water sources and there are dangers with formula, this is indeed the correct thing to do. But prolonged breastfeeding, nevertheless, is associated with a 10 to 15% increased risk of HIV transmission. And that means that interventions have had to take place which could prevent mother-to-child transmission in those settings. So the first really nice bit of evidence came from Laura Gui and Philippa Musoke working in Uganda. They published in The Lancet in 1999, where they were able to demonstrate that giving just one dose of nevirapine to mum and one dose postnatally to baby had a dramatic reduction in mother-to-child transmission rates in a breastfeeding cohort. And that this reduction actually continued this was sustained up to 18 months. And so that got the world excited. This was the time of the Durban AIDS conference. And there was tremendous excitement that here was an intervention that could be applicable to resource-poor settings. And then not too long after that, Mark Lallemont, working here actually with Dr. Ken McIntosh in Boston, produced some very nice data, sort of talking about the benefits of giving nevirapine, again 2 doses of nevirapine, short course zidovudine, and that either a single dose to mum or baby was even more efficacious than giving zidovudine alone. So that began sort of a study, that began, these 2 studies from Laura Gui and Mark Lallemont really began the study and the science of providing prophylaxis in breastfeeding populations. Not too few years later, Taha, working in Malawi, was able to look at 3 arms and look at the effects of nevirapine to breastfeeding infants and to give nevirapine for 14 weeks. And again, compared to the control arm, the investigators were quite nicely able to demonstrate that postnatal prophylaxis for 2 weeks, at least, during the breastfeeding period was associated with a reduction in mother-to-child transmission, shown in the figures. If you look at, say, 9 months, the figures in the control arm were 10.6%, but 5% for the extended nevirapine arm, and with nevirapine and zidovudine, 6.4%. So clearly there was going to be some benefits about providing antiretroviral therapy postnatally to babies who are being breastfed.
So just to clarify, you talked about a single dose, and then you talked about a prolonged dose, and it was 14 weeks. Is that correct? That the baby would be taking daily for 14 weeks?
Yes, to 14 weeks, yeah.
We'd like to turn to the audience now and ask a question. When you respond, can you please leave your city and country location? The question is this: in low-resource settings, the recommendation currently is that mothers continue to breastfeed even if they are HIV positive. Tell us a little bit about the experience you're having in your setting with maintaining breastfeeding in the face of maternal HIV infection. So what about maternal health? What was being done to keep the mothers healthy during and after pregnancy? Are there any trials to show that giving antiretrovirals to the mothers during breastfeeding and not only keep them healthy, but also doing better with nursing their infants?
Yeah, this is a critical component. We really need to address the, not only sort of, it's fantastic that we prevented mother-to-child transmission, but keeping mums healthy as well is so critical to newborn health, pediatric health, which runs right the way through to adolescence and early adulthood. And so one of the really important studies that actually came out from investigators from Boston who are working amongst a group in Botswana, Roger Shapiro and others, they sort of published the Mbana study in 2007. And here they sort of had cohorts which were provided with combination antiretroviral regimens. And importantly, in the 3 arms, the mothers maintained good virologic suppression beneath 400 copies, beneath the level of detection. So that was really great to see, because that meant that they were healthy during pregnancy and during breastfeeding. But importantly also, there were very few transmission events. There was sort of 1% overall transmission in the infants over 6 months. And so this really sort of showed that maternal virologic suppression during a period of breastfeeding was associated with significant reduction. These were the lowest rates of mother-to-child transmission in a breastfeeding population that was recorded. And also importantly, that the regimens were safe and well tolerated for both women and their breastfeeding infants. And so the conclusion was from the group was that maternal combination antiretroviral therapy from early in the 3rd trimester of pregnancy through 6 months of breastfeeding is a safe and very effective strategy for preventing mother-to-child transmission while allowing for the benefits of breastfeeding. There is one worry that came through, and this was published more recently from the same group, which is that although we're now seeing a number of exposed but uninfected babies from Botswana, some of these babies are dying sooner than we would expect. These exposed, HIV-exposed, uninfected babies who remain uninfected constituted about 38% of deaths compared to babies who were in the control arm who were not HIV exposed. And that is now an emerging area in terms of why HIV exposed uninfected babies are dying at such striking numbers. And we don't quite know yet why. The conclusion, the follow-up conclusion from this fantastic news that was published in 2007 to this particular piece of evidence is that in a programmatic setting with widespread maternal and combination antiretroviral therapy available for mother and child, exposed children contribute to more than half of the overall deaths. That's going to be an area of investigation. In that same journal which published Dr. Shapiro and his group, that data, Charles DeSela and others in the BAN study also demonstrated the benefits of maternal antiretroviral prophylaxis and also postnatal prophylaxis in infants receiving nevirapine, extended nevirapine for 6 months in a breastfeeding cohort. And you can see compared to the control arm, there are significant differences. As a side study, there was also some work that showed that giving cotrimoxazole to these exposed uninfected babies was associated with improved survival. And again, in the context of the more recent work from the Botswana group of increased infant mortality in exposed uninfected babies, we're going to have to see if there'll be some benefit with this antibiotic. This is sort of the alphabet soup of a number of studies that have taken place in the past decade and a half. The SWEN study, the PEPI Malawi study, the BAN, the ANRS study, the PROMISE study, Keisha Bora, and all of them are pointing to the same direction. And so where are we heading? Well, we're going towards option B+, which is sort of now recommending triple antiretrovirals antenatally as soon as mum is diagnosed. This is amazing stuff considering where we were back in 1992-93 for all mums globally. And that should be continued not only up to the point of delivery, but throughout life. And that providing prophylaxis with nevirapine or zidovudine or a combination thereof will help significantly in offsetting transmission. And so these are the guidelines, the option B+ guidelines that have come through from the World Health Organization.
We would like to turn now to the audience to ask a question. When you respond, can you please leave your city and country location? The question is this. We've presented to you all of the recommendations for keeping mother healthy, having a healthy birth and delivery, and then keeping the baby healthy. Very complicated recommendations. What are the barriers that you're facing in your location to meeting these recommendations from the World Health Organization?
And to sort of almost to confirm that, we have the ongoing PROMISE trial from the NIH looking at 3,500 women in India, Malawi, South Africa, Tanzania, and a number of other countries. And again, I think we haven't got the data back yet from this particular trial, but I think all the pointers are suggesting that there's going to be significant benefit. The only one worry, well, apart from the other concern that I mentioned about exposed uninfected newborns having increased mortality, is that there are concerns about higher preterm delivery associated with antiretroviral therapy. Nevertheless, transmission rates are very low. And this is sort of some of the data really highlighting that. The tentative conclusions currently from the PROMISE trial are that they support the WHO 2013 WHO recommendations for triple combination regimens in pregnancy for HIV-infected mothers. But these regimens may be associated with a higher risk of moderate but not severe adverse maternal and pregnancy outcomes, including preterm birth and low birth weight. But the risk of early deaths in the combination arm is a bit anticipated in one of the particular arms and will require a little bit more investigation. Nevertheless, at least globally, the recommendations are that PMT-CT is enhanced with early initiation of combination antiretroviral therapy in pregnancy, and if it's maintained throughout breastfeeding and indefinitely thereafter. That the fixed dose combination of one particular drug called tenofovir with lamivudine and efavirenz is recommended by the World Health Organization. This benefits mum. This also is associated with protection from sexual transmission to partners. People think that this is maybe costly in the short term, but far more cost effective over time. That breastfed infants should receive this prophylaxis with nevirapine daily for 6 weeks, and that uninfected infants breastfeed for 6 months. That cotrimoxazole may have health benefits in exposed uninfected infants, but there are some safety concerns on antiretroviral drug exposure. We're still unclear why exposed uninfected infants have higher mortality, but that is an area of investigation. Nevertheless, we've made tremendous progress on prevention of mother-to-child transmission in Western settings and globally over 2 decades, which is really amazing considering where we started from and considering progress in many other conditions. It's taken a village to get this far. But there are still significant challenges, and we have to address these in the coming decades. Thank you.
We'd like to turn to the audience now and ask a question. When you respond, can you please leave your city and country location? The question is this: in your setting, have you seen any examples of exposed, uninfected children in the HIV situation who are having these illnesses and early deaths? Rana, thank you so much for helping us understand this very, very important area, and thank you for all the work that you do in this field.
It's been a privilege talking to you and the group. Thank you.